Hi, I'm Dr. Kunal Chawla, a consultant at Sir Gangaram Hospital, Delhi, and the director at Dr. Chawla's Diabetes Care Clinic, Delhi. Today, I'll be talking about thyroid nodules and how to do a fine needle aspiration of thyroid nodules. First of all, a bit about the thyroid gland. The thyroid gland is a large butterfly-shaped gland that sits low on the front of the neck. The gland secretes the thyroid hormones, namely T3 and T4. These hormones regulate growth and development through our body by manipulation of the rate of metabolism. The gland has two side lobes which are connected by an isthmus in between. But what is a thyroid nodule? A thyroid nodule is any abnormal growth that forms a lump in the thyroid gland. These abnormal growths may be picked up either clinically or as a neck swelling on an ultrasound. Thyroid nodules are surprisingly common and are seen in 12% of Indians. So once we have identified a nodule in a patient, what do we do next? Do we worry about it? The answer to that is we don't need to worry, as 99% of the thyroid nodules are actually benign and only 1% turn out to be cancerous at the end. So once we have identified the thyroid nodule, what do we do next? First of all, we order a thyroid function test. If the thyroid function is abnormal and the TSH is low, then a nuclear scan should be ordered. If the nodule is hot on scan, malignancy is unlikely and the patient should be managed by an endocrinologist as a case of toxic nodule. What we do next is an ultrasound of the neck. Now there are two main systems of classification that are used, the ones endorsed by the British Thyroid Association and the ones advocated by the American Thyroid Association. As in my place of work, we use the ATA. I will now be continuing as per them. The reference for these guidelines can be found in the comment section below. Now the ATA guidelines ultrasound classification of thyroid nodules. Now as per the ATA, a diagnostic thyroid neck ultrasound should be performed in all patients with a suspected thyroid nodule, nodular goiter, or any radiographic abnormality suggesting a thyroid nodule, incidentally detected or another imaging study. The ATA classifies thyroid nodules into one of the following categories with varying suspicions of cancer on basis of ultrasound findings. These categories are highly suspicious for cancer, intermediate suspicion for cancer, low suspicion for cancer, very low suspicion for cancer, and benign lesions. A lesion is said to be having a high suspicion for cancer if it is solid or hypoechoic, or if it's solid hypoechoic with a partially cystic nodule, with irregular margins, microcalcifications, taller than white shape, rim calcifications with extrusive soft tissue component, with extrathyroidal extension. A lesion is said to be of intermediate suspicion of cancer if it is a hypoechoic solid nodule with smooth margins, without the presence of any of these three features, that is microcalcification, taller than white shape, or without any extrathyroidal extension. A low suspicion lesion is usually isoechoic or hyperechoic solid. It may be partially cystic nodule with eccentric solid areas. However, the three things, microcalcifications, taller than white shape, and extrathyroidal extension, need to be absent. A spongiform or a partially cystic nodule is usually classified as having very low suspicion of cancer, and a purely cystic nodule is classified as a benign lesion. Now in this ultrasound, you can see some areas of microcalcifications. You can see the lesion overall is hypoechoic and the lesion seems to be irregular in shape. So this is probably highly suspicious of cancer. Another lesion with specks of microcalcification, a hypoechoic nodule and an irregular shape, again suspicious of cancer. This is a lesion. This is a well circumscribed lesion with cystic areas. So as cystic areas without a solid component, well circumscribed, this is in favor of it being a very low suspicion or benign lesion. Here we can see an isoechoic nodule which is well defined. We can see the margins. So this again is in favor of a low risk ultrasound picture. This again has a low risk ultrasound picture, so is again in favor of a benign lesion. So all this is fine. This classification on basis of ultrasound is fine. The question is, when do we need to do an FNAC? ATA recommends FNAC at more than equal to 1 centimeter in people with high or intermediate suspicion pattern on ultrasound. FNAC at more than 1.5 centimeters in people with low suspicion of malignancy on ultrasound. ATA suggests to consider FNAC at more than 2 centimeters size in those with ultrasound features suggestive of very low suspicion of malignancy. However, another thing which can be done is observation without FNAC. That is also a reasonable option according to them. And as for the ATA, no biopsy is necessary with benign ultrasound pattern. So now that we've decided for which lesions we do need to do an FNAC, so how do we go about it? How do we do an FNAC? Step 1 is, of course, we need to obtain an informed consent. Step 2 is positioning. We should place the patient in supine position with the neck slightly hyperextended. For that, we can place a small rolled towel behind the patient's shoulders. Subsequently, we should sterilize the skin with either alcohol or betadine solution. Local anesthesia, which can be either 1% buffered lignocaine, is then administered to the biopsy site intradermally and then to deeper tissues adjacent to the thyroid capsule. Now this can be done under image guidance. Now what this does is, apart from providing an anesthetic effect, this 1% lidocaine provides an anechoic area on ultrasound adjacent to the thyroid that allows better visualization of the needle. Now using a 27 to 25 gauge needle for thyroid FNA, we introduce the needle into the thyroid nodule under ultrasound guidance. We use a needle without a syringe and we depend upon the capillary action of the needle for aspiration. The needle is directly introduced into the nodule and a series of advance and withdraw motions are performed at least 3 to 5 times while gently spinning the needle in a clockwise and counterclockwise direction. We need to do 3 to 5 separate needle FNACs for each nodule. The ideal dwell time is 2 to 5 seconds within the nodule, and a biopsy rate of 3 forward and backward oscillatory movements per second has been shown to improve the cellular yield and minimize blood artifact. Specimens should then be flushed into cytology solution in preparation for cytoanalysis. The neck is then cleaned with rubbing alcohol and a small bandage is applied on the skin surface. Patients are then discharged to home with the advice to seek additional medical evaluation in the event of progressive swelling or ecchymosis at the biopsy site. They should be advised not to take any NSAIDs for the next 36 hours and use paracetamol for pain control. So once the FNAC is done, how does the pathologist report it? A thyroid nodule FNA cytology should be reported using diagnostic groups outlined in the Bethesda system for reporting thyroid cytopathology. The Bethesda system recognizes 6 diagnostic categories and provides an estimation of cancer risk within each category based upon literature review. The 6 categories are: number 1, category 1 is non-diagnostic, category 2 is benign, category 3 is atypia of undetermined significance or follicular lesion of undetermined significance, Category 4 is follicular neoplasm or suspicious for follicular neoplasm, including Hürthle cell neoplasm. Category 5 is suspicious for malignancy. And category 6 is frankly malignant. So what is the usual course of action? For category 1, that is on non-diagnostic nodule, FNA should be repeated with ultrasound guidance and, if available, an on-site cytological evaluation. Surgery should be considered for histopath diagnosis if the cytologically non-diagnostic nodule has a high suspicion ultrasound pattern, or if the nodule grows more than 20% in 2 dimensions, or if there are some specific clinical risk factors for malignancy. A category 2 lesion, that is a benign lesion, does not require any surgery or does not require any further intervention. Category 3, for nodules with AUS and FLUS cytology, a repeat FNA or molecular testing may be used to supplement the malignancy risk assessment instead of adapting a strategy of either surveillance or diagnostic surgery directly. The outcome of these can determine whether we go for the surgery or whether we wait and watch. For category 4, diagnostic surgical excision is a long established standard of care for the management. However, of late, molecular testing is also being used to supplement the malignancy risk. For category 5 and category 6 lesions, the patient should go for surgery and usually has to undergo a near total thyroidectomy or a total thyroidectomy. Thank you. If you like the video, please click the like button.